everyone. My name is Eunice Mamick. I am the Coordinator of Community Relations and Resources at Cystic Fibrosis Canada. On behalf of our Adult Cystic Fibrosis Advisory Committee, I would like to welcome you all to the first of an 8-part series on fertility and family planning for people with cystic fibrosis. The Adult Cystic Fibrosis Advisory Committee is a standing committee of Cystic Fibrosis Canada. The committee provides perspective and advice on CF-related issues and advocates for public policies and programs to help people with cystic fibrosis. Members also foster and support an engaged and knowledgeable CF community. Among the committee's various initiatives, we are pleased to start this webinar series today, through which different aspects of fertility and family planning will be discussed by a variety of expert guest speakers, as well as people living with CF that are willing to share their personal experiences. Please note, this is an educational webinar series. We at CF Canada cannot provide any medical advice. Although the series will feature a few CF clinicians and other health professionals, we highly recommend that all persons with CF seek guidance from their CF clinic care team regarding their personal family planning process. Today, we are honored to be joined by Dr. Tullis. Dr. Tullis is responsible for the care of more than 500 adults with CF. Dr. Tullis is a professor of medicine at the University of Toronto, the respirology division head at St. Michael's Hospital, and an adjunct scientist at the Keenan Research Center of Li Ka-shing Knowledge Institute. Additionally, she holds the Cystic Fibrosis Canada Chair in Adult CF Research. Dr. Tullis has published over 130 articles and book chapters and has lectured nationally and internationally on issues related to CF in adults. She has trained 20 CF fellows who are now working in CF clinics around the world. In 2012, she was awarded the Queen Elizabeth II Diamond Jubilee Medal to recognize her contributions to the care of people with cystic fibrosis in Canada, and in 2017, she received the Dr. Douglas Crozier Award from Cystic Fibrosis Canada in recognition of her significant contribution and outstanding dedication to the fight against cystic fibrosis. In 2017, she received the Region 3 Prix d'Excellence Specialist of the Year Award from the Royal College of Physicians and Surgeons of Canada. The Adult Cystic Fibrosis Advisory Committee is pleased to have Dr. Tullis speak on our first topic of the series, fertility issues in men and women with cystic fibrosis. Dr. Tullis, over to you.
Thank you very much for the very kind introduction, and thank you today. I'm very excited about being part of this series and getting to do this sort of initial presentation. The topics are of great interest to me and to the team at St. Michael's Hospital, and we'll have people from our clinic and people working in our clinic that will be listening to this as well. So what I'm going to talk about today is fertility issues as they affect women and men with CF, and this is really just the first of a discussion of treatments and pregnancy, etc. And of course, there's more details about various different aspects in future talks. So we'll just forward things here. So I think that the reason we get to have this conversation is because people with CF are living longer. And as I'm sure this audience knows, that the survival for people with CF in Canada is the best in the world. And Dr. Stevenson reported a few years ago that there is a difference in survival of people with CF in Canada compared to the United States, which shows there's a whole decade longer in terms of median survival in Canada. And because of that, it means that there are more and more adults with cystic fibrosis. And in Canada, about 60% of people with CF are over the age of 18. And obviously, as people get into adulthood, they start thinking about having children and their fertility. Now, as long ago as 1995, which is, over 20 years ago, there was a paper published by some CF doctors in Australia. And they were interested in knowing what people with cystic fibrosis thought about reproductive health. And so they did a survey of people in the Melbourne clinic, and they got 55 women responding. And the majority of the women were, in fact, planning to start a family at some point. However, when they asked a series of questions related to fertility and pregnancy in people with CF, they realized that the CF clinics hadn't done a really great job of providing education to people with CF about the fertility and pregnancy issues. At that time, about a quarter of the women who responded had tried to conceive with a success rate of about 67%, or 2/3. So you can see that this was an issue 20 years ago, and is obviously probably more of an issue now, given the fact there's so many more adults with cystic fibrosis. So to start off with, I thought it's sort of useful to talk about what is important in female fertility, and then I'll focus in on what are the issues in fertility in women with CF. So the first thing is that for fertility purposes for women with CF, everything starts in a sense with the ovary and the egg production. So you need to ovulate, which means that you need to be able to, the ovaries make eggs, and ovulation is the release of the egg. And the egg is released, and it passes down the fallopian tubes. And as it passes down the fallopian tubes, it will meet, for conception to occur, sperm that is traveling up from the vagina through the cervix, into the uterus, and into the fallopian tubes. And fertilization occurs in the fallopian tube. And once the egg is fertilized, it moves down to the uterus, where it implants in the wall of the uterus. And implantation needs to happen in order for the pregnancy to take. So you need sperm. You need to have eggs that are produced in the ovaries. You need to have the egg and the sperm to meet in the right spot in the fallopian tube. And then you need the uterus to be the right kind of environment and ready for implantation. Now, in CF, the issues are related to the fact that CFTR is actually in the uterus, in the cervix, in the fallopian tubes. And so it's present through the female reproductive tract. And CFTR, which is the CF chloride channel, is both a chloride channel and a bicarbonate channel. And as a chloride channel, it impacts how, the hydration, how wet the secretions are. And as a bicarbonate channel, it impacts the pH, or acidity, of the secretions. So when you look at the role of CFTR in the reproductive tract, it depends where you're looking. So CFTR in the cervix is what creates the mucus plug that kind of blocks the between the vagina and the uterus. And what happens in women is that the mucus in the cervix is different at different parts of their cycle. The mucus tends to be on the thick side. It's almost like acting like protection between the outside of the body and the inside of the body. It's like a plug. But right at ovulation, when the egg is released and a woman is fertile, these secretions normally get very thin, very watery. And that's because the CFTR is working to increase the water content of this mucus plug. And what that means is the sperm can swim through the liquid plug at mid-cycle when the woman is fertile. Now, the problem in people with CF is that thinning of the secretions at ovulation doesn't happen because CFTR is not working. So the mucus plug stays thick and sticky and acts as a barrier to sperm. So sperm can't even get through the mucus plug in the cervix. Now, the second thing that CFTR does, its role in the uterus, is to regulate the amount of fluid in the uterus. And there is always a small amount of fluid in the uterus, but at the time of ovulation, there is more. And the purpose of that is it's to provide an environment that is good for the sperm to sort of swim through these secretions to get up to the fallopian tubes. And then at the second part of the cycle, when an egg might be fertilized and is coming back down into the uterus, you want the fertilized egg to implant in the wall of the uterus. And at that stage, the role of CFTR is to shut off, so there is no fluid. So now the walls of the uterus close together on top of each other, and that helps sort of almost push the fertilized egg into the wall. So what happens in people with CF is they don't have that fluid environment for the sperm to swim through the uterus, and then they don't have the right environment for the fertilized egg to implant. And so the problem is now you've got an issue with the sperm getting through the cervix, and then if it gets through the cervix, it's not in a very good environment in order to swim up to the fallopian tubes, and then it's not in a good environment to implant. On top of it, CFTR also functions as a transporter or channel for bicarbonate, and that impacts the pH of the secretions, how acid the secretions are. And that's important because the acid-base balance in the uterus is important to actually kind of activate the sperm. And there's this process called capacitation, which is where the sperm is activated in order to fertilize the eggs. And to do so, it needs a non-acidic environment. And the problem is in women with CF, the acid kind of content of the secretions in the uterus is too high. It's too acidic. So the sperm never get activated in order to fertilize the eggs. So when you stop and think about it, there are multiple reasons why women with CF might have trouble. Their cervix has a thick plug of mucus and the sperm can't get through. If the sperm does get through, the environment in the uterus isn't very good. The mucus isn't thin enough for the sperm to swim through it. The sperm is not activated, so it's not very good at fertilizing the egg. And if the egg is fertilized, the environment's not so good for implantation. There are some other factors that influence fertility in women with CF. One of them is a woman's nutritional status. If women are too thin, the body sort of decides that this is not a good time for pregnancy to occur because the mother's nutritional status is not good enough to sustain a pregnancy. And so what happens is that people who are very thin, women who are very thin, for whatever reason, don't ovulate. And so they just don't make eggs at all, and so there is no egg to fertilize. We also have some evidence to suggest that people with CF might have fewer eggs or a lower ovarian reserve, and that's based on mouse models as well as some studies in women with CF. And there may be actually an impact on the embryo, so the actual fertilized egg, as there's some evidence that in the mouse model, the bicarbonate concentration impacts how the embryo develops. Now, we don't have a good idea of how important those roles are in fertility in women with CF, but the previous slides about the mucus in the cervix and the uterus, we have a much better idea of how important that is. So when you hear all that, you think, yikes, like, how can women with CF even get pregnant? And many years ago, we really didn't know that answer to the question because initially women with CF were sort of advised don't have children, or they weren't really well enough to have children. So it was really hard to determine if a woman is fertile or not, because if you're not trying to get pregnant, you can't tell if you're fertile. The first reported pregnancy in a woman with CF was in 1960. And since that time, you can see on the graph below, there have been increasing numbers of pregnancies each year. These are the data from the United States, showing that every single year that goes by, and every 5-year gap, every year there are more and more pregnancies seen in people with CF. And I'm sure the numbers are similar in Canada, but obviously a lot smaller because there are fewer people in Canada than in the United States. So women with CF can get pregnant, but it's really difficult to predict who will be able to conceive. So it's one of these things, if you don't want to get pregnant, then it's important not to assume that you're going to be infertile. And likewise, if you do want to get pregnant, you can't sort of say, I'd like to get pregnant when I'm 26 and start trying at 26, because there is a chance that you might have difficulty in conceiving. So what happens if someone's not able to conceive? Now, these are just guidelines that we have in our clinic. But assuming a woman's health from a CF point of view is good and she's stable, that means her nutritional status is good and there's not a lot of problems with lung infections, meaning that the body is sort of healthy and that ovulation is likely to be occurring because somebody is medically well. If we notice that a couple is unable to conceive after trying for 6 to 12 months, then we suggest an assessment by an infertility gynecologist and an assessment of semen analysis to make sure that there isn't a male factor problem. We know that in infertility in general, half of the problems with fertility that couples have are related to male factors and half are related to female factors. Now, what treatments are there available to women with CF who are unable to conceive naturally? Well, when you think about the two problems that exist, one of them is this thick mucus plugging the cervix. So one method of sort of assisted reproductive techniques is intrauterine insemination of sperm. And so that basically means getting a sample of sperm and using a syringe and a catheter, a rubber catheter, to inject the sperm directly into the uterine cavity. Now, the problem with this is it doesn't get around the fact that the environment in the uterus may not be ideal for fertilization to occur. Again, not enough thin secretions in the uterus and too acid an environment so the sperm don't get activated. The second way of dealing with it is in vitro fertilization. And that's the process where the woman's eggs are stimulated, so multiple eggs are stimulated to grow by using medications that are injected in order to sort of hyperstimulate the ovaries. And then those eggs are extracted by a needle. And so all the eggs are taken out of the woman's body and put in a test tube where they are then fertilized with the partner's sperm. And then once you have the fertilized embryos, then one or two of them are implanted back into the uterus in order for the pregnancy to continue. So women with CF can get pregnant naturally. If they don't get pregnant naturally right away, then we do the testing to make sure there isn't a male factor, and then we can look at either intrauterine insemination of sperm or in vitro fertilization in order for the woman to conceive. So what are some of the factors to consider prior to pregnancy? So there's some things that it's really good to talk to the CF team about ahead of time. One of them is just like, what are the potential challenges for pregnancy and, in fact, for looking after a child? And sort of sitting down and going over that and putting that in the context of one's own health and the other challenges that people might have with their health. So do they have diabetes, or are there issues with bowel problems, or is nutrition a bit of a challenge? So having just sort of talking about pregnancy in the context of your CF. Now, because the woman with cystic fibrosis will always pass on in all of her eggs, there will be a CF mutation. It's very important to have the genetic testing of the partner in order to see if the partner is also a carrier. If the partner is a carrier, then there's a risk that the baby will have cystic fibrosis. There's ways around preventing that from happening, even if the partner is a carrier. But you don't know what the risks are until you've done the genetic testing. The next thing that's important is to make sure that your health is optimized. Your nutrition is the best it can be. Your lungs are good. You're not having a lot of chest infections. Your lung function is the best it can be and stable. And if you have CF diabetes, you have good blood sugar control because that can affect fertility and a pregnancy. If you don't have diabetes, it's important that you're screened ahead of the pregnancy, because people who are sort of on the borderline or who have diabetes that hasn't been recognized, that's really important to know at the beginning of a pregnancy, because treatment of diabetes is very important during a pregnancy, or otherwise there's problems for the baby. And then finally, there's a discussion about all of the medications and how they might impact fertility and how they might impact pregnancy. And those include the regular CF medications as well as the new CFTR modulators like ivacaftor or Cambi or Symdeko. And then for people who are thinking of going ahead with pregnancy, you need to make sure that you're getting your prenatal vitamins. So although there's going to be a separate webinar on pregnancy and CF, I think it's really important to answer this question, which is, does pregnancy make CF worse? And this has actually been answered in multiple ways with large studies using the registries like the Canadian registry and the US registry, as well as single center studies which are looking like what are the results, for example, in Toronto, or what are the results in London, what are the results in a single center. And all of these studies seem to show that women with CF who get pregnant don't have a worse outcome than women with CF who don't get pregnant. So that pregnancy itself does not make the CF worse. It's the CF factors that are more important in determining how a person does, which is what's your lung function like, what bacteria you have in your lungs, how many chest infections you're having. But having said all that, many clinicians have had a bad experience. And that, what I mean to say by that is that people with CF, whether you're male or female, and whether you're pregnant or not, sometimes get sick suddenly and unexpectedly. And obviously, if this happens when someone is pregnant, it's very traumatic for the person themselves, obviously, but also for their healthcare team. So that pregnancy itself does not cause a deterioration, but CF can be unpredictable, and we all need to think about what those consequences might be. There's also going to be another webinar about other options to have children if you decide not to get pregnant yourself, and that includes adoption and surrogacy. And I'm not going to discuss this now because this will be another topic for a future webinar. But there are other options that women with CF have chosen to take. Now I'm going to move on to male fertility. And to start off with, again, it's just sort of understanding the sort of process of fertility. So sperm are made in the testes, and they move into the epididymis, which is a series of small coiled tubes that sits on top of the testes. And it's in these small coiled tubes that the sperm is stored and the sperm matures. The sperm moves up the vas deferens, which is the tube that leads from the testes, and it joins up with the urethra to leave the body through the penis. There's other secretions that are added through the prostate gland and the seminal vesicles. Now, in cystic fibrosis, sperm function, meaning like making sperm or spermatogenesis, is normal. So men with CF make sperm. And their testosterone levels are also usually normal, although sometimes puberty may be delayed, especially if the man is of low nutritional status. The big problem in men with CF is that vas deferens, that tube that leads from the testes out through the urethra, is not present. And it appears that it's not present right from birth. This isn't a problem of a tube that gets blocked, like your pancreas. This is really a problem of a tube that gets blocked at a very, very early stage of development. So even children with CF, and in the olden days, 40, 50 years ago, if a post-mortem exam was done on a child with CF who passed away, they could see where the vas deferens should have been, but it isn't actually a tube. There's also problems with small or absent seminal vesicles, and some of the other parts of the male reproductive tract don't form properly. Now, not every man with CF is infertile, but it is probably even a little bit higher than 98%. Some CF mutations are mild enough that it appears that the vas deferens does form normally, but that's less than 2% of men with CF. And you may get a clue based on your genetic test results, but the only way to know if you're fertile or not is to do a semen analysis. A semen analysis is collection of the sperm and examination under a microscope, and they look at the semen and they see if there's actually any sperm present there. So men with CF, the problem with their fertility is what's called azospermia, and azo means none, and spermia is sperm. So it's basically there are no sperm in the semen, and it's due to congenital bilateral absence of the vas deferens. That means congenital, since birth, bilateral, both sides, absence of this vas deferens tube. So I think a man with CF has to assume that they're infertile unless they've had a semen analysis. Now, the problem is that infertility doesn't mean impotence. Men with CF have normal sexual function. So there really isn't any way of telling without doing the semen analysis and actually looking at the semen to see if sperm is present. So a lot of times people think, well, I should be able to tell if I'm infertile, and the answer is not really. One clue is that the volume of ejaculate is less than somebody who doesn't have CF, but that's not something that's really very easy to quantify. So there really isn't any way of knowing if you're infertile without doing the semen analysis. Now, the same study that I had quoted from 1995 was repeated 10 years later by the same author, now talking to young men with CF and asking them what do they want to know about fertility and family planning. And what they found when they did the survey in Australia, that men with CF wanted to find out they were infertile from their CF team. And they wanted to find out really before they were an adult and before they had gone to the adult clinic. And the younger it was that you sort of heard about it, and the fact that you heard about it by the CF team as opposed to like hearing about it on websites or from other patients was sort of less likely to be upsetting. Now, all men should understand that to answer the question of fertility, a semen analysis is available, and people should be told that when you want to answer that question, we can arrange for semen analysis to be done. So it should be offered to everyone. I think it's really important to clarify that infertility is not the same thing as impotence. And men with CF also from this study wanted information on what were their reproductive options. What were their options to have children? So options for men with CF to have children are adoption, artificial insemination with donor sperm, or using advanced reproductive techniques of sperm aspiration, something called ICSI, which I'll explain, and in vitro fertilization. So artificial insemination with donor sperm, until 20 years ago, this was the only option. And many men with CF that I know who have children, their children were conceived through artificial insemination. And that means that using donor sperm is that the children are not biologically the children of the man with CF. Nowadays, there are options with IVF, but sometimes people choose still to do donor sperm and insemination because there's not the risks or discomforts or cost that there exist with IVF. And it's a little bit sort of easier to do with respect to the timing of things. The cost is considerably less. It's probably about 1/10 the price of IVF. if people want to do assisted reproductive techniques, basically the problem in men with CF is that they make sperm okay, if they just can't get out of the body. So you have to actually take the sperm out of the testes and do in vitro fertilization, or basically put the sperm and the egg together outside the body and then implant the egg. So the first techniques to do this were way back in 1985, a procedure called MISA, or microsurgical epididymal sperm aspiration. And this was an operation where there's a little incision made. The man was asleep, and there's a little incision made, and a micro needle, tiny needle, was put in the epididymis, these coiled tubes on top of the testes. And the sperm were aspirated or sucked up in a syringe from the epididymis. And so that was a really good way of doing it, that you got a lot of sperm, and because you were getting them from the epididymis, the sperm were quite mature. And so that was sort of the gold standard, the best way of doing it. But the problem was it was an operation. You had to be put asleep for it. And so then they moved on to percutaneous techniques, and that means doing something through the skin with local anesthetic, but not a general anesthetic to knock you out. And these are either PISA, or percutaneous epididymal sperm aspiration, or TISA, testicular sperm aspiration. So PISA is where you put a little needle into the epididymis, but instead of doing an incision or a cut to get into the epididymis and so be able to see it directly, you do it through the skin. So it's local freezing in the area to minimize pain, and then a skilled urologist putting this little tiny needle into the epididymis and sucking up the sperm. A testicular sperm aspiration is doing the same thing, but doing this in the testes. And that the disadvantage of that is that it's a little easier in some ways because the testes is larger than the epididymis, but the testes has more blood supply to it, and so there's more problems with bleeding and swelling afterwards. You don't get quite as much sperm as you do with the open procedure, but still enough. And as I said, there's a higher risk of a hematoma, which is a bruise. Now then you've got the sperm. And the problem with the sperm in men with CF is although they're taking it usually from the epididymis, it's not quite as mature. So if they take the sperm and they take an egg through IVF and they put them on in a test tube together, the sperm are kind of not strong enough to actually fertilize the egg. To fertilize the egg, the sperm has to burrow through the wall of the egg to get inside. And the sperm are sort of immature enough just because they don't have the normal anatomy to allow for them to mature. So they're not so good at fertilizing the egg. So what they do is this procedure called ICSI, or intracytoplasmic sperm injection. So what you're seeing in this slide is on the left you're seeing a micropipette that's kind of holding that round or oval-shaped egg in place. And on the right-hand side, you're seeing a needle. And if you look really carefully in the middle of the needle, there is one sperm. And this needle is slowly being advanced into the egg, and then the sperm is injected into the egg. So they're basically fertilizing the egg with a needle containing the sperm rather than letting the sperm do it on its own. And when they learned how to do this technique, that's what made the huge change in outcomes. This is when this process of taking the sperm out of the body, taking the egg out of the body, and putting them together went from being something that was really not very likely to be successful to something that actually worked. And the problem is, as you can imagine, this whole thing is rather costly. There's the cost related to aspirating the sperm. There's the cost related to the IVF program, the drugs related to that, the getting the eggs, then doing the combination together and doing this ICSI procedure. So it's costly, and unless people have good private insurance coverages, this process is not covered. And so what happens after they fertilize the egg stays in a test tube for a few days until it is grown large enough and they can see that the fertilization hasn't successfully occurred. And then they transfer the embryos around day 2 or 3 into the woman's uterus, and they give hormones to help support the pregnancy until it's further along. So when you look at the results of doing the IVF and ICSI in men with CF, and these are very old papers now. These are all from 2000 and 2006. So these are already 20 years old. The success rates of baby are over 50%. So fertilization rates means did it work in the test tube? Pregnancy rates mean did the woman become pregnant? And live birth rate means did the woman have a baby? So it's over 50%, and this is even 20 years ago. So the results that are quoted are generally over 50% success rate, and that's been very much the experience that we've seen. The twins, of course, comes on how many eggs you put in, because if you're going to put 2 eggs in and they both survive, then you're going to have twins. And so generally speaking now, because of the problems of having, twins is a more difficult pregnancy in general and a little harder on the babies, generally speaking, they're less likely to put 2 embryos in at the same time. So in conclusion, looking at all this, it's pretty clear that even 20 years ago, people with CF wanted to have children. And as people with CF are living longer and living older and living better and feeling healthier, this is a very reasonable expectation that we certainly, the CF healthcare providers, certainly wish their patients to have the option of having a family. CFTR is important both in male and female fertility, and women can conceive, but it's unpredictable who will be able to conceive without difficulty and who might have a little bit more problems and who might need to use assisted reproductive techniques. However, women with CF who get pregnant, the pregnancy itself doesn't make their CF worse. Men with CF are likely to be infertile because of the absence of the vas deferens, and assisted reproductive techniques have a high degree of success. And like everything else in life, planning is everything. Surprise pregnancies are not advised. Whether you have CF or not, surprise pregnancies are probably not the best way of doing things. But what we find is that the CF team, as well as the team of obstetrics and urologists and fertility experts, and all the other aspects of the CF team, the nurses, dietitians, physios, respiratory therapists, pharmacists, and social workers, are all important in planning for pregnancy and making sure people are in a good place to start a family and supporting a woman through the pregnancy. So at this point, I'll stop and see if there are any questions.
Thank you, Dr. Tullis. So we do have a few questions our participants sent in when they registered for the webinar. Just for everybody that's online, if there are any additional questions, please use the chat box to send in your questions and I will read them all out. So Dr. Tullis, the first question we had come in was, what are some helpful questions I should ask my CF care team about fertility and family planning?
So I think what's important is a helpful question is sort of a discussion about how is my CF, in terms of my stability, like where am I in my CF that thinking about starting a family, like this is the right time, and how would I optimize my health? And are there any barriers at this time or any problems at this time? time? Because I've sort of talked about it very generally, and some people with CF are like there isn't really anything to do. Their health has been stable and everything's looking good. But then other people might perhaps be on one of the new CFTR modulators, and that might be an issue. Or some people might have problems with CF diabetes and their blood sugars be a bit high. So I think one thing is to take these general concepts and apply it to you and sort of say, how am I if I wanted to have a family now?
Thank you. Someone online just wrote in and said, I missed the part about CFTRs having an effect on pregnancy. If possible, can you give a quick recap?
Okay. So basically, CFTR doesn't seem to affect the pregnancy itself. So it affects whether you're able to get pregnant if you're a woman. But once you're pregnant, the CFTR protein doesn't seem to play a role. So the pregnancy itself is pretty much the same as anyone else. And that the multiple studies have shown that women with CF who get pregnant don't do worse than women with CF who don't get pregnant. So the pregnancy itself doesn't lead to a deterioration in one's condition. I think that answered the question.
That's great. Thank you. The next one is, what is the chance that my baby would also have CF?
So that's a great question. And to answer that, you actually have to look at your partner and do genetic testing. So as I said, whether a man with CF or a woman with CF, your sperm or egg will always have a CF mutation if you have CF. If your partner does not carry a CF mutation, then all of your children will be carriers of CF, but none of them will have CF. So every baby born to a man or a woman with CF, if their partner isn't a carrier, the baby will be a carrier. But remember, carriers have no signs or symptoms and no health problems. Now, if your partner is a carrier, there's a 50% chance that your baby will have CF. And that means the partner has to do the genetic testing and get the result. And if they find a mutation, there's a 50% chance the baby will have CF. There are actually ways around it. If you want to have a child, but you don't want to take the risk of the baby having CF, you can do in vitro fertilization, and then they can test the fertilized embryos at the sort of day 3 of life, and they can take one cell and do the analysis and do genetic testing, and they can work out which of the embryos would have CF and which of the embryos would not have CF, and then they can decide to just implant the embryos that don't have CF. So your risk is either sort of almost zero, but every baby would be a carrier, and if your partner is a carrier, the risk is 50%.
Thank you. The next question is, what kinds of medication do men with CF have to go off in order to retrieve sperm, and how long do they have to go off such medication in the context of ICSI?
Yeah, great question. So, most of the medications that people with CF are on are actually really safe. So the standard, inhaled antibiotics, azithromycin, pancreatic enzymes, medications to affect gastric acid, insulin, epomazine, all of those things are very safe. So a man with CF doesn't need to stop any of those therapies. The question comes with the CFTR modulator drugs, so that's Kalydeco, Orkambi, Symdeko. And the problem is the studies were done, and people who did the studies had to be on birth control, so they couldn't conceive. Generally speaking, the CFTR modulators, what you want to do is, we don't know if they're a risk or not, but to be safe, people would go off the medications long enough that they would be washed out of your system. because the sperm are produced quite frequently. So men with CF are always making sperm. The sperm can't get out of the testes, so it just breaks down and gets absorbed into the body. So the sperm are being made all the time. And so generally speaking, that if somebody would do a washout period, that would be sort of in the range of 1 to 2 months. And then that would make sure the drug is completely out of the body, and therefore the sperm wouldn't be affected. Now, we don't know, in fact, if that's necessary to do, but to be on the safe side, that's the time frame. If a man with CF also has other conditions like, for example, seizures, or these are not CF conditions, these are completely unrelated medical problems, then you'd have to talk to your CF doctor or your CF pharmacist to find out what the half-life of the medication is, to see if the medication needs to be stopped or not. And if it does need to be stopped, obviously you might be at risk for whatever the underlying condition is. Is there a safer medication to be on so that you don't have to stop the treatment? But CF in general, the medications are really very safe.
The next question, I'd like to know more about extreme or unexplained infertility cases in males with CF. My husband has CF, but after 5 years of trying, doctors are stumped as to why IVF is not working for us.
So that's a great question. And, obviously, as a lung specialist in CF, you might argue that I'm not the best person to answer it. But I'll take a general stab at it. There's two things to remember. One of them is that people with CF can have other reasons for difficulty conceiving. So that they might have nothing to do with CF. It might just be sort of bad luck to have other forms of infertility as well as having CF. So sometimes it is like looking to see if there is another reason why a man or woman would be unable to conceive. Sometimes from a female factor, sometimes it can be very, very difficult to understand why IVF hasn't worked. So for example, say a man has CF and you've done IVF, and a woman has not been able to successfully become pregnant. The problem may be with the husband's sperm, with some problem with actually the sperm or other genetic issues other than CF, or the problem might be related to the woman, and it might have something to do with, again, the environment in the uterus, not related to CF, but related to other conditions. And there seems to be, when you just talk to people, your friends, people, that who have had difficulty conceiving, you see that often it isn't clear what the problem is. And so that same thing can happen with CF. There can be more than one factor other than the CF, and that's the bit that sort of stumps people because they can't really find a reason for it.
Thank you. Our next question is CBAVD directly caused by mutated CFTR? Is it specific to CF?
Yeah, that's a really great question. So the answer is pretty much. So the condition of CBAVD, 90% of the time, there is evidence of CF gene mutations. So in 90% of men who lack a vas deferens, it's because of mutated CF gene. In 10%, it's another problem, and the other 10%, the men have other problems with their urinary tract anatomy. So, for example, in the 10% of men with CBAVD that don't have CF mutations, those men usually just have one kidney. So there's a problem in the anatomy, and that the problem is they only have one kidney and they have no vas deferens. So it's a completely different process going on, but that's only 10% of the time, and 90% of the time it's related to CF mutations. And sometimes the CF mutations are very mild, and this is how CF gets diagnosed in adult men. They kind of present to medical attention not because of lung or digestive problems, they present because of infertility. And they're found to have an absent vas deferens, and then they have CF testing, and lo and behold, they have a very mild form of CF. And so it's one of the ways that CF gets diagnosed in older people. So the short answer is yes, most of the time absent vas deferens is due to a mutation in the CF gene.
We have two more questions. The first is, when is the right time to have that initial chat about the likelihood of pregnancy in individual cases? Is there a certain amount of time before a couple begins to try that doctors should be informed?
Well, my feeling is that, if you're kind of certain that you found the person you want to start a family with, I think you should have the conversation early. I think even if you think, well, I don't want to get pregnant now because I'm only 25 or I'm only 23 or I'm only 26 and I'm not kind of ready in my life to do that, I think you should have the conversation early so you just sort of understand what the process is, and also so you can have that sort of assessment of your CF to see, are there things that you could work on to sort of optimize your health. And so I think, you're armed with information, and also some of the things take a while. Like genetic testing can take 3 months to get the results back. And we have to assume that for a woman with CF, that pregnancy might not happen right away. And we're not going to necessarily do anything until people have been trying for around 6 to 12 months. So you don't know if you're going to get pregnant on the first try or if it's going to take you a year or so. And going through fertility clinics and things like that. In addition, these assisted reproductive techniques, unfortunately, are not covered by government insurance programs, and private insurance may not cover the whole cost. So I think it's good to have the conversation early and sort of see what the options are and decide if, do you want to sort of start a savings account to sort of put money aside for a future family.
Thank you. And the last question is, are there any studies on the negative effects CF medication might have on male infertility, including Kalydeco or Orkambi?
So there haven't been because, basically, when you test a new drug, they're deliberately done to, in the state, to avoid a pregnancy because you just don't know. There are animal studies that are done on these medications where they look for evidence of problems with sperm, problems with babies that are born, like birth defects in people and animals, I should say, that are taking these medications. So they do some testing of sort of fertility and safety in animal studies, but really it's only time that is going to kind of answer the question about what it's like for people with CF. Already in the States being like a big market and them having earlier access to drugs like Kalydeco and Orkambi, and Symdeko is pretty early on. But there are women with CF who are conceiving that are on these medications. And so there's case reports and there's discussion at these sorts of things at CF conferences. There doesn't appear to be problems, but the numbers, of course, of people who have actually been pregnant on these drugs is still very small. And I know that that my patients who have been interested in sperm aspiration and have been on these medications have decided to take a bit of a drug holiday for 1 to 2 months before doing the sperm aspiration, just to be on the safe side. And so a lot of the times there's just people are just avoiding the risk, so we're not actually seeing we're not getting the experience to see what it is.
Great. Well, thank you, Dr. Tullis, for taking the time to join us to speak on fertility and family planning for people with living with cystic fibrosis. And thank you to everyone on the call as well. As we said, this is the first of an 8-part series, so our next webinar will be on fertility treatment options, and that will be in April. We invite you all to keep an eye on our Facebook page for more information on the series, and like always, all questions can be directed to advocacy@cysticfibrosis.ca. This webinar was recorded and will be made available for future viewing. Thank you, everyone.